Hi everyone, this is Doc Ina and this is my lecture on bioethics. To download my lecture deck for free, please go to my WordPress site, Docina Obigaine. These are my main references for this lecture. So what is bioethics? Bioethics is a subset of ethics that provides reasoned and defensible solutions that incorporate ethical principles for actual or anticipated moral dilemmas facing clinicians in medicine and biology. It deals with relationships between practitioners and patients, practitioners and the society, and society and the patients. Bioethics regulates the relationship between the healthcare provider and the beneficiary of healthcare. It addresses ethical issues in clinical practice and healthcare, biomedical research involving humans and animals, and health policy in the environment. So, what started the field of bioethics? The development of the principles of modern bioethics is inextricably linked to the contents of the Belmont Report. The Belmont Report reports about the Tuskegee, Alabama Public Health Service funded syphilis research, which ran over a period of 40 years from 1932 to 1972, and this involved inhuman experimentation on 400 indigent Black American males. The Tuskegee Syphilis Study was an American medical research project that earned notoriety for its unethical experimentation on African American patients in Alabama. This was conducted by the U.S. Public Health Service, which examined the natural course of untreated syphilis in African American men. The research was intended to test whether syphilis caused cardiovascular damage more often than neurological damage, and to determine if the natural course of syphilis in black men was significantly different from that in whites. So, in order to see the natural course of syphilis among these patients, the subjects were not told that they had syphilis and that the disease could be transmitted through sexual intercourse. Penicillin, which is the gold standard in the treatment of syphilis, was denied to these infected patients, and it was still being withheld from them even 25 years later. The Tuskegee syphilis study finally came to an end in 1972 when the program and its unethical methods were exposed in the Washington Star. A class action suit against the federal government was settled out of court for $10 million in 1974. The termination of this research led to the establishment of the United States National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, and they published their findings and recommendation, which is now known as the Belmont Report of 1979. The Belmont Report provided an analytical framework to guide the resolution of ethical problems arising from research involving human subjects. So, the major principles that are commonly invoked as guides to professional action and for resolving conflicting obligations in healthcare are the following: the principle of beneficence, the principle of non-maleficence, the principle of respect for autonomy, and the principle of justice. Other principles or rules include fidelity, honesty, privacy, and confidentiality, which are also important whether they are viewed as derived from the four broad principles or as independent. These bioethical principles will be discussed in the later slides. So first, we discuss the principle of beneficence. The principle of beneficence states that it is the physician's obligation to give highest priority to his patient's welfare and provide competent healthcare that maximizes health benefits for the patient. It is the ethical responsibility of the physician to do and maximize good. And this principle also emphasizes what is best for the patient with respect to preventive and curative healthcare. Here are some examples exhibiting the principles of beneficence. First is when the patient is incapacitated by the grave nature of accident or illness. So we presume that the reasonable person would want to be treated aggressively, and we rush to provide beneficent intervention by stemming the bleeding, mending the broken, or suturing the wounded. Also, in the treatment of suicidal patients who are a clear and present danger to themselves, the physician should intervene on behalf of saving the patient's life or placing the patient in a protective environment in the belief that the patient is compromised and cannot act on his own best interest at the moment. So imagine yourself as the ER doctor or the doctor at duty in the ER. So you see a patient coming into the emergency room bleeding profusely from a gunshot wound who has lost consciousness due to massive blood loss with no other relatives seen accompanying the patient. What will you do? So as physicians, it is our primary obligation to treat this patient and to save his life at the best way that we could, even if there's no consent from the relatives or the patient himself. So again, another scenario. Imagine yourself the ER doctor or the doctor at duty at the ER. So a man comes to the emergency room at 2 a.m. needing emergency treatment from a hacking wound to the face and head with massive bleeding. He's actually dying because of this massive bleeding. And you learn that this patient is the same suspect who killed their close relative a few days ago. What will you do? So as physicians, we have to uphold the principle of beneficence and treat this patient the best way we could and try to save his life. Another example under this principle is when we do episiotomy to a parturient woman to prevent a third-degree laceration of the perineum. Next is the principle of non-maleficence, and this refers to the ethical duty of the health practitioner to do no harm or cause pain to the patient. The physician should recommend treatment options which pose minimal or no harm to his patients. This upholds the Hippocratic imperative to physicians: bring benefit and do no harm. Examples of this principle include doing sensitivity tests prior to IV drug administration, prescribing oral antibiotics for which the patient has no known allergy to. And it is considered a breach of this principle when we do episiotomy or suture the episiotomy without local anesthesia in a patient who has given birth. It is also considered a breach of this principle when we perform CS or cesarean section on a term pregnant patient for no medical indications. A good example of this principle is when we refer a patient to a specialist who can adequately manage our complicated cases instead of managing the patient on our own. And also an example is referring patient to other competent healthcare providers when we refuse to perform a requested medical procedure. The third principle is the principle of respect for autonomy. According to Boychamp and Childress, the principle of respect for autonomy supports a number of more specific rules, including the following: telling the truth, respect the privacy of others, protect confidential information, obtain consent for intervention with patients, and when asked, help others make important decisions. In medical practice, the principle of respect for autonomy implies personal rule of the self that is free both from controlling interferences by others and from personal limitations that prevent meaningful choice, such as inadequate understanding. Respect for a patient's autonomy acknowledges an individual's right to hold views, to make choices, and to make actions based on her own personal values and beliefs. Respect for autonomy provides a strong moral foundation for informed consent in which a patient, adequately informed about her medical condition and the available therapies, freely chooses specific treatments or no treatment at all. Respect for patient autonomy, like all ethical principles, cannot be regarded as absolute. At times it may conflict with other principles or values and sometimes must yield to them. The principle of respect for autonomy requires that the physician respect the rights of patients to make independent decisions as an expression of their self-determination. And this principle is the basis for the practice of informed consent in the physician-patient transaction regarding healthcare. Some of the examples that exhibit this principle include the following. So, for example, you have a cancer patient at a terminal stage with painful gastrointestinal obstruction due to stage 4 cancer, and this patient chooses to forego chemotherapy or CPR. So, By the principle of autonomy, we must respect this patient's decision to forego chemotherapy or to forego CPR. Also, imagine yourself as the physician in charge of a terminal cancer patient who's coming from a poor family who decides to forego life-sustaining medical technology. For example, he wants to forego breathing support or a breathing apparatus. Then, by the principle of autonomy, you have to respect that decision. Also included under examples of principle of autonomy are informing the patient about his prognosis and disclosing all details of treatment that this patient will undergo, and also when a VIP patient requests that his case not be divulged to the media or his relatives. Number 4 is the principle of justice. Justice in healthcare is usually defined as a form of fairness or giving to each that which is his due. This is the ethical responsibility to uphold fairness and equity in medical care. It refers to the equitable distribution of potential benefits and risks. The question of distributive justice also seems to hinge on the fact that some goods and services are in short supply, there is not enough to go around, and thus some fair means of allocating scarce resources must be determined. It is the most complex of the ethical principles to be considered because it deals not only with the physician's obligation to render to a patient what is owed, but also with the physician's role in the allocation of limited medical resources in the broader community. It underlies concerns about how social benefits and burdens should be distributed. For example, is it fair that two patients otherwise similarly situated are treated disparately by the healthcare system because one is rich and the other is indigent? Other examples under this principle include who should get the priority in organ transplant. Should prioritization be on a first come, first served basis or a case to case basis? So, for example, you have two patients who need kidney transplant, and you know how rare kidney donors come, right? So, on one hand, you have an elderly patient with terminal cancer who needs a kidney transplant. And then on the other hand, you have a young patient in her 20s who has a better prognosis, who also needs a kidney transplant. So who do you give or who do you set as a priority for the kidney transplant? Is it the elderly patient with a poor prognosis or the patient who is younger and has a better prognosis? Of course, you have to give the kidney to the younger patient with a better prognosis. Another example, should you recruit poor patient for your research because they badly need the monetary compensation? Of course, that is unethical. You shouldn't lure a poor patient for your research because of money. Let us discuss other bioethical principles. So the fifth is the principle of human dignity. This principle requires that all healthcare decisions must aim to promote human dignity and result not only in physical health but also satisfy the patient's psychological, social, spiritual, and cultural needs as an individual and as member of the community that he belongs. For example, patient has the right to choose or refuse treatment depending on his preference, culture, or religion. The best example for this principle is a Jehovah's Witness patient who refuses a life-saving blood transfusion. Number 6 is the principle of free and informed consent. This is derived from the basic principle of respect for autonomy. This is the concrete expression of respecting the patient's autonomy, and it comes in two levels. The first is autonomy of capable persons, which upholds patients' right to voluntary informed consent and choice based on comprehension of available options. Example, the patient's right to family size determination. The second level is the protection of persons incapable of autonomy. These include the unconscious, the mentally subnormal, and the child, all of whom require the protection of their autonomy. Example, the decision on the treatment of an unconscious pregnant woman lies on probably the husband, or if there's no husband, the parents. Genital mutilation of an infant. Okay, so who has a say on that? should be the parents, or in the absence of the parents, the grandmother or the grandparents. Elements of a valid informed consent include the following: the competence of the patient, adequate information, comprehension and understanding of information presented, and free voluntary consent. The information that should be included in recommending a diagnostic or therapeutic procedure for a patient include the following: complete description of the procedure, reason for the proposed procedure, benefits of the procedure, risks of the procedure, alternative diagnostic or therapeutic options, and freedom to ask questions. In cases of incompetent patients who cannot provide consent, proxy decision makers, that is the husband, the parents, the relatives, or the guardians, should make the decision according to the patient's best interest. So who are the incompetent patients incapable of autonomy? There's the unconscious patient, the mentally subnormal or the mentally challenged patient, and the child or a minor. Protection of the incompetent requires either the presence of a living will, especially in the case of an unconscious patient, or obtaining of consent from the surrogate proxy decision makers, or if option number 2 is not feasible, a clergyman or the ethical committee of a health institution, or as a last resort, the law court. The attending physician can invoke therapeutic privilege and can give consent based on his obligation to provide health care. For example, in the case of a ruptured ectopic pregnancy in shock with no available relatives, then the physician can invoke his or her therapeutic privilege in order to save the life of this patient, even in the absence of available relatives. Medical paternalism refers to the overriding of autonomy. So, strong paternalism is the overriding of the autonomy of a capable person and is not ethically permissible. Weak paternalism is the overriding of the autonomy of an incapable person, which is permissible if performed for the overall well-being of the person. Number 7 is the principle of a well-formed conscience, or the principle of veracity. This requires that physicians, as responsible healthcare providers, have the following obligations: inform themselves as fully as possible about evidence-based medical facts and ethical norms, form a morally certain judgment of conscience based on above information, make healthcare decisions according to his fully informed conscience, and accept responsibility for their actions. The ethical principle of veracity enjoins healthcare practitioners to tell the truth in explaining the potential benefits and risks alike involved in whatever treatment being given to and procedure being carried out on the patient. Number 8, the principle of totality. This requires that all persons should develop, use, care for, and preserve all his physical functions in such a way that lower functions are never sacrificed, except for the better functioning of the whole person or to preserve life. Examples for this principle are the following: an atonic uterus causing heavy postpartum bleeding may be removed to preserve the life of the patient in the form of a hysterectomy. A gangrenous foot may be amputated to prevent the spread of infection. Number 9 is the principle of professional communication. This requires that health professionals have the following responsibilities. First is to establish and preserve trust in their patients, share medical facts they possess that are legitimately needed by patients to have an informed conscience, refrain from lying or providing misinformation, and keep secret information not legitimately needed by others that, if revealed, may harm patients or destroy the patient's trust. Number 10, the principle of confidentiality. This requires the physician to keep the privacy of patients about those aspects of life which do not directly affect others. This principle is not absolute. This may be broken by the need to protect the patient or others from harm. Number 11, the principle of double effect. This is derived from the basic principle of non-maleficence, and this refers to actions which may have both good and bad effects. Four conditions must be fulfilled for the principle to be allowed, and these are the following: that the action must not be intrinsically contradictory to one's fundamental commitment to God and neighbor. The action must be good or at least indifferent. The intention of the agent must be directed towards the beneficial effect. The harmful effect is only allowed, never directly intended. The foreseen beneficial effects must be greater than or equal to the harmful effects, and the beneficial effect must proceed from the action ahead or simultaneous with the harmful effect. It is important to note that in general, the mother should be of prime consideration, and therefore decision on her well-being takes precedence over that of the fetus. Some of the best examples under the principle of double effect are the following. So first is a pregnant patient at 25 weeks AOG who has breast cancer stage 3 or stage 4 and has to be given chemotherapy. Of course, in these cases, we have to give chemotherapy for this breast cancer patient without delay, even though we know that there are detrimental effects on the fetus because of chemotherapy. So we have two effects here. One is the beneficial effect of the chemotherapy on the breast cancer of the patient, and the harmful effect is, of course, the possible detrimental effects on the fetus. Again, this is doing or giving chemotherapy on this breast cancer patient is still ethical because the intention is directed towards the beneficial effect. And the harmful effect, which is the detrimental effects on the fetus, is not directly intended. And again, as I've said in the previous slide, in general, the mother should be of prime consideration. Okay, so the well-being of the mother takes precedence over the fetus. Another good example is a pregnant patient at 28 weeks AOG with cervical cancer stage 2B. And this patient has to undergo cesarean section at 28 weeks and then undergo hysterectomy thereafter. So we have two effects here. The good effect is, or the beneficial effect is the hysterectomy for cervical cancer patient. Of course, we have to save the life of this patient, and so we have to do hysterectomy. But the harmful effect is, of course, doing cesarean section on a premature with a premature fetus. Again, the intention is directed towards the beneficial effect, which is curing or treating the cervical cancer of the patient. And the harmful effect, which is the prematurity of the fetus, is not directly intended. And therefore, doing cesarean section at this early AOG is considered ethical. Number 12, the principle of stewardship. This refers to a man's limited dominion over nature and his own life. These things were entrusted to him to care for and improve as responsible steward. Health professionals have ethical responsibilities to use intelligence and available technology to prevent and cure diseases. Number 13, the principle of fidelity. This refers to the ethical responsibility of all health practitioners to carry out whatever promises made to a patient in relation to activities for which he or she has been employed. So for example, a pregnant patient was used for the purpose of a clinical examination or an OSCE for professional medical students exams, and she may have been promised free further antenatal care and delivery. So under the principle of fidelity, we must honor our promise to this patient even though we've already finished the OSCE or the clinical examination because we promised her that. Number 14, the principle of scientific validity. Medical practitioners have responsibility to ensure professional competence and scientific soundness in the conduct of medical care or research on patients. So in summary, we have discussed the four basic principles: the principle of beneficence, the principle of non-maleficence, the principle of respect for autonomy, and the principle of justice. We also have discussed the other bioethical principles, which are usually offshoots of these four basic ethical principles, and these are the principle of human dignity, principle of free and informed consent, the principle of well-formed conscience, the principle of totality, principle of professional communication, the principle of confidentiality, the principle of double effect, the principle of stewardship, principle of fidelity, and lastly, the principle of scientific validity. That's it, and thank you for watching. Please don't forget to subscribe in my WordPress site, Doc Ina Obigaine, and my YouTube channel, Ina Irabon.